needs therapy.
Psychosomatic.
That boy needs therapy.
You're psychosomatic.
That boy needs therapy.
Lie down on the couch. What does that mean?
So, I think it would be useful if we started by your telling me something about your state of mind at the moment. How would you describe it? Would you say you were happy or depressed? Confident or unsure of yourself? What words would you use to describe your mood, would you say? Take your time.
Fascinating, absolutely fascinating. Your problem seems to center around the delusion that you are a psychiatrist.
Fry and Laurie, when they weren't so famous or ubiquitous as they now are, make fun of psychiatry, and they do so by taking the traditional view that psychiatry as a practice is mostly about talking to people. There's certainly something in this, but in reality psychiatrists undertake a variety of roles. Here's an American psych talking about his typical day.
My name is Dr. Kennan, and I am a psychiatrist working at an academic institution. My typical day is I arrive on the unit around 7:45 on an inpatient facility, and I will usually round for 3 to 4 hours with the medical students and residents, seeing patients, writing orders, and then sometime around lunchtime I usually give a lecture and do that for the lunch hour, take a short break and go over and see patients then in an outpatient clinic where I watch or see patients for somewhere between 10 and 15 minute appointments up to an hour-long appointments. That's my typical day. In the inpatient setting, I see people that are often in crisis. They can be there court-ordered against their will and often suffering from severe mental illness or serious mental illness as defined by the state, such as schizophrenia, bipolar or psychosis, severe depression. Often they've become a danger to themselves or others. I also then work in an outpatient setting where I see people that have either recovered from those acute stressors and are doing better, or maybe have something like a milder form of depression, anxiety that's under control. I also see people that suffer from memory disorders, eating disorders. So I see a large spectrum of patients in a large variety of ways that they're getting treatment either through medications and sometimes complemented.
Again, we probably aren't overly surprised about this story. Dr. Keenan works in hospitals and an office. His day is divided between the two. He sees acute patients, maybe those who've suffered a psychotic crisis, and he sees chronic patients under long-term care. We know that he'll be doing a bit more than the pseudo-psychiatrist Ryan Laurie. But in recent years, the business of working as a psychiatrist in a clinical context has become far more complex. Psychiatry, more than any other part of medicine, has been influenced by the biopsychosocial model, which is a subject for exploration elsewhere in Minds and Madness. This means a good psychiatrist will be attuned to the biological, the psychological, and the social circumstances of any patient she sees. This has resulted in the creation of a new role within the hospital, the Consult Liaison, or CL.
Many of the services we provide in the NHS split physical from mental health, and what we do in liaison psychiatry is try and bring the body and mind back together again. People come to hospital for help with symptoms, and commonly physical and psychological symptoms occur together. So if someone is struggling with a chronic painful illness like arthritis, it comes as no surprise to us that they might feel low or depressed. If you have diabetes and you are depressed or anxious, that will have an impact on how you manage your illness, and there is good evidence that psychological interventions can lead directly to improved control of your blood sugar. It's also more than just providing a shoulder to cry on. People that we see often lose hope and feel at the end of their tether, and a good intervention by liaison psychiatry can be life-saving. And of course, this doesn't just apply to the work we do in hospital, but also to the wider community too.
The CL is like a super coordinator whose job it is to liaise between different services, ensuring that the patient and the patient's family are able to access all the resources they need during this time of stress and emergency, including the social services. They might as well call in other specialists to treat sequelae or figure out what services a patient is going to need on discharge. There are other things that psychiatrists get up to too. Training other psychiatrists, giving expert testimony in the courts about the mental state of those accused of a crime. They might even be part-time neuroscientists, putting aside their therapeutic role to join multidisciplinary teams trying to figure out just how the brain works. But one thing that you won't find them doing is working in an asylum. The institutions which for the best part of 150 years or more dominated the treatment of madness, because these institutions, as we know, have gone the way of all things. How different the landscape now to what it was, say, 50 years ago. What it meant to be a patient or a practitioner has completely metamorphosed. And this change will be the principal subject of this lecture. In the process, we're going to see how psychiatry emerged out of mainstream medicine, first as mad doctoring, then alienism, before finally becoming psychiatrists. But even at the point they call themselves psychiatrists, they can barely be regarded as specialists. That would have to wait until the 20th century. But for now, I'm going to provide some context about the medical profession, exploring how it evolved over a very wide expanse of time. So here I'm going to introduce the historical structure of medicine to give us an indication of how it was going to evolve. From way back when, sometime in the early Middle Ages or even before, a lot of these roles go back to the Romans, medicine in England and a lot of the rest of Europe was structured in this way, or at least in a very similar way. At the top of the medical ladder were the physicians. These were the highest status of all. Below them were the surgeons, who were often united with the barbers, so you could go for a bleed and a haircut. And below that were the apothecaries who compounded the medicines that the physicians would prescribe. And it's from these roles that the organisation of the entire structure of modern medicine evolves. In England, the physician was at the top of the tree. University educated, they and they alone had the right to call themselves doctor, for they had studied for an MD, a Doctor of Medicine. Right the way through the 18th century in England, these men came from a relatively high social status because only the wealthy could afford to attend Oxford and Cambridge. It was slightly different in Scotland. In Edinburgh, for example, the medical education was cheaper, but was generally better fitted for the surgeons, although until the 19th century they did not offer bachelors in medicine or surgery. The physician tended to be book educated. This was in effect library medicine. However, increasingly during the 18th century, part of that education would involve doing the rounds of the hospital and observing disease. But the emphasis must be on observing. They had little physical contact with the patient. They might examine the patient's urine or feces. They might look at the patient's tongue. They might even feel the patient's pulse, but not much else. Their concern was to give advice, putting the body back into balance, and prescribing medicines or other interventions, which they themselves did not carry out. They might, for example, as in the case of King George III, order emetics to make him vomit, purges to evacuate the bowels, and bleeding to quell the mania. But none of these things would they do themselves. This would be left to assistants, possibly surgeons or apothecaries. In effect, they prescribed medicine, but they did not supply it. That, as we will see, was the apothecary's duty. In terms of their professional affiliations, they had a royal college that licensed physicians, and for which the fellowship was much prized.
He's bleeding now. I can't stop the blood. More gauze pads, please, hurry.
Next down in the pecking order were the surgeons, or as they were until the mid-1750s, the barber surgeons. For up until this period, the two roles were combined. If you've ever seen the red ribbon on the white pole that you sometimes still see outside of barber shops, you should realise that this symbolises the two roles, the white for shaving cream, the red for blood. You might, if you were so minded, think nothing of popping down the barbers for a shave and a bleed. The barber surgeons were organised within a guild, the medieval institutions that controlled access to particular occupations. To become a guild member and to have the right to practice an occupation, you had to undergo an apprenticeship of many years. The separation of the barbers and the surgeon may well have been a result of the rising status of the surgeon's craft, an acknowledgement, if you like, of how specialised surgery was becoming. Think, for example, of William Cheselden's operation for cataracts. To become a surgeon, therefore, required serving under a surgeon as his apprentice. You would attend the cases he attended, learning how to dress wounds, to bleed patients, to stitch wounds, or to apply bogies or setons to irritate the skin. If you don't know what I'm talking about, go and look for some on the web. You would even learn operations like amputation, which you might at some point be required to carry out if you were unlucky. Not a pleasant thought. During the 18th century, it became more common for apprentice surgeons to attend courses at hospitals or private schools where they would receive anatomical training and increasingly hands-on dissection. And because of things like the nature of warfare, surgery developed at a pace that medicine did not. Battles required effective surgeons who worked with dexterity and speed, and it needed a lot of them. By the end of the 18th century, the role of the surgeon had risen to such a status that their college in London was granted a royal charter, sanctioning by law their right to confer licenses to practice on those that had passed their exams. The bottom rung of the ladder was occupied by the trade of apothecary. These were the men who blended herbs, concocted medicines, and supplied prescriptions. They too were apprenticed, but they operated out of shops. The pharmacy or chemist is the direct descendant of the apothecary's shop. And this associated them with the low-status designation of shopkeeper or trader. It was, however, impossible to stop them from prescribing in their own right, and by the early 19th century it was not uncommon for medical students to take exams set by the Society of Apothecaries, no royal prefix here, as part of their medical training. The role of pure apothecary morphed into that of chemist.